Good morning, this is Dr. Hiba Ghannoum, lecturer of audiovestibular medicine, Helwan University, and our topic today is approach to dizzy patient. What do we mean by dizziness, or how do we define dizziness? Dizziness is an imprecise term, a broad term, that is used to describe a variety of symptoms, different symptoms. Each of these symptoms has a different pathophysiological mechanism and significance. طيب, what's the role of primary healthcare physician and why is it crucial مع a dizzy patient? Because as you will see, we are facing vague symptoms. So primary healthcare physician will have to differentiate between the benign conditions that might be behind this dizziness from other life-threatening serious conditions that might be causing dizziness. So we need a diagnostic algorithm to determine or to differentiate dizziness caused by life-threatening conditions from dizziness caused by benign conditions, and accordingly primary healthcare physician will be able to whether further manage the case or refer it or ask for more investigations. Dizziness is classified into 4 categories: vertigo, disequilibrium, presyncope or syncope, and lightheadedness. How do we define each of these categories? Vertigo يعني إيه؟ يعني true spinning. Vertigo, whenever we the patient describe vertigo يعني دوار، يعني لازم يبقى فيه true spinning أو rotation of the surrounding. Whenever we say true vertigo يبقى لازم يكون في حاجة اسمها nystagmus. True vertigo يعني spinning يعني rotation يعني nystagmus. طيب, what about disequilibrium? Disequilibrium is the sense of being off balance, يعني sense of imbalance while standing or while walking, and it might be associated with falls in specific direction. What about presyncope or syncope? Presyncope يعني impending loss of consciousness, as if the patient will faint. Lightheadedness يعني ايه lightheadedness? This is a vague symptom لما البيشنت يكون مش عارف يوصف. He's not feeling well. How to approach a dizzy patient? Several studies have recommended to start our approach to dizzy patient by asking him or her to answer a questionnaire. What's the importance of answering such a questionnaire? Actually, it gives the patient a chance to describe the emotional, the physical, and the extent of the functional impairment caused by his dizziness. Moving on to history taking, and we will discuss this in details, followed by examination, general examination, ENT examination, and neurootological examination, which will be the scope of this lecture. History taking. As I mentioned, appropriate history taking is the key to reaching the proper diagnosis. So in 70% of patients, you might be able to reach the diagnosis alone by history taking. And then you confirm your diagnosis by the bedside examination, the office tests, and the other special tests. In history taking, ask the patient to أول حاجة to describe the attacks or the episodes اللي هو بيشتكي منها in his own words. What are the key points in history taking? أول حاجة, is it vertigo or not? زي ما قلنا ال overlap in symptomatology في vestibular patients بيخلي الموضوع شوية كل العيانين هيدخل يقول لك أنا عندي دوخة. You have to make sure what does he mean by the term دوخة. Is it true vertigo ولا it's not? True vertigo يعني في spinning يعني في rotation. If not, you have to decide بقى with the patient whether it's disequilibrium, whether it's lightheadedness, whether it's sense of imbalance, whether it's presyncope, all the other terms that we have mentioned earlier. What about the time course of the attack? The time course of the attack is very important to reach a proper diagnosis. Time course of the attack might be seconds to minutes, minutes to hours, or hours to days. And please note that this is very important also. You have to ask the patient about if it is vertigo, you have to ask the patient about the time course of the attack of the vertigo. يعني الspinning استمر قد إيه. Because most of the patients will suffer a sense of imbalance after the episode of the attack. يعني الspinning might last for seconds, but following the attack the patient still has a sense of imbalance. فيجي يقول لك it lasted for hours, although the spinning itself did not last for hours. So you have to make this very clear. The time course of the attack of the spinning itself lasted for how long. Then you have to ask about the precipitating factors. زي إيه ممكن precipitating factors? Was it a head movement? Was it changing your position? Loud noise. The attack was following a certain diet or a certain medication. What are the accompanying symptoms during the attack? Did you experience any kind of hearing loss, sense of occlusion in the ear or ear pressure? Did you experience tinnitus, a headache, drop attack? Did you experience amplification of sounds? Sounds were louder during the attack. So these are the accompanying symptoms that we can ask for. Also, if the patient is describing true vertigo, as I mentioned, we have to know if it's episodic, if it comes in episodes, يعني بتيجي في certain attacks. We have to know the duration of each attack كانت قد ايه، بتقعد قد ايه، the number of times اللي اتكررت فيها، حصل الtrue spinning ده حصل كام مرة، وآخر مرة حصلت كان إمتى, when it last occurred, and finally if there are any triggering if there are any triggering events that cause attack to happen. Now we move on to examination. Examining a dizzy patient, thorough general examination and ENT examination are mandatory, and remember to exclude when you're performing the general examination, remember to exclude orthostatic hypotension. We move on to neuro-otological examination. Neuro-otological examination includes cranial nerves examination, nystagmus, oculomotor tests, vestibulo-ocular reflex test battery, and finally assessing the posture and gait of the patient. Now we start the oculomotor tests. We are mainly searching for nystagmus. First, we have to check that the patient has a full range of movement in all planes. How do we do this? We ask the patient to follow the examiner's fingers in all planes of movement, and we check that there is normal eye movement in all planes. Then we start searching for spontaneous nystagmus. We ask the patient to fixate his vision on a certain target that is approximately 4 feet away from the patient. This target might be the examiner's finger as well. If we find nystagmus, then we have to record the amplitude and the direction, whether it's horizontal or vertical, of this nystagmus. After fixation, we have to test for spontaneous nystagmus, but without fixation, by abolishing fixation. How do we abolish the fixation? By using goggles, Frenzel goggles. Why do we abolish the fixation? Because subcortical inhibitory mechanisms are activated by the visual fixation. The vision, the ability of the patient to fixate his vision, will activate subcortical inhibitory mechanisms, and these subcortical inhibitory mechanisms will lead to inhibition of the vestibular generated spontaneous nystagmus. يعني if there might be vestibular spontaneous nystagmus, but you are not able to see this because of the visual fixation. So in case we haven't found any spontaneous nystagmus with fixation, يعني البatient شايف بالvision, then we have to ask the patient to put on the goggles and retest this patient for spontaneous nystagmus تاني ونشوف without fixation will we be able to record or to see any spontaneous nystagmus أو لا. normal result لو normal patient هيبقى no nystagmus found. In case the nystagmus is noticed, then again we have to record the direction and the amplitude of this nystagmus. The next test is the gaze test. How do we perform it? The technique is that the patient fixes his gaze at an object or the examiner's finger, 18 inches from his nose, 30 degrees to the right and 30 degrees to the left, at horizontal planes, and then we also test at vertical planes up and down. يبقى يمين وشمال 30 degrees by the examiner's finger, and the patient has to fixate his gaze on your finger that is 30 degrees, to the right, to the left, and then on the vertical plane. Normally there will no be nystagmus. الابnormal اننا نلاقي persistent nystagmus, and please note the word persistent because you might be في حاجة اسمها endpoint nystagmus. You might find 3 or 4 beats. This is called the endpoint nystagmus. بس الابnormal ان احنا نلاقي persistent nystagmus. Another test for the oculomotor function is the tracking test, horizontal and vertical tracking, or what we call smooth pursuit. We use again the examiner's finger is located 18 inches away from the patient, and the patient is asked to track the examiner's finger that's moving in 30 degrees to the right and to the left. Normally the patient can perform a smooth tracking movement with his eyes on the horizontal and the vertical levels. The abnormal is what we call cogwheel pattern, or we find corrective saccades or asymmetry in the movement. cogwheel يعني بنلاقي ان الموفمنت فيها correction، بنلاقي الموفمنت متقطعة زي السنان بتاعة الكوجويل، فبنلاقي ان الموفمنت اكن فيها تقطيعة كده. And this signifies ايه؟ ده probably بيكون central vestibular deficit. Another test for assessing the oculomotor function is the saccades test, the horizontal and the vertical saccades. But this time we are assessing the quick movement of the eye, the quick eye movement from one target to another. Again, I'm using my fingers or the examiner's fingers that are located 18 inches away from the patient, and the patient is asked to follow or to focus on one target and shift to another quickly. And I'm noticing ايه اللي انا بلاحظه movement. Is it accurate أو لأ؟ Is it conjugate both eyes together ولا في disconjugate eye movements؟ الabnormality ان انا الاقي inaccuracy, the patient is shooting away from the target، او الاقي disconjugate eye movements، او الاقي الشيفت السرعة بتاعته انها في حاجة اسمها slow saccades. كل الحاجات دي alarming signs لإيه؟ كل ده زي smooth pursuit. These are alarming signs for a central vestibular deficit. Now we come to the VOR assessment, the vestibulo-ocular reflex. We previously mentioned that the VOR permits the maintenance of clear vision during head movement or rotation. طيب, how do we test for VOR? The first test is called head impulse test، وده بيعتمد على حاجة خدناها زمان في الفسيولوجي اسمها doll's eye reflex. How do we perform the head impulse test? We grasp the examiner grasps the head of the patient and flex it 30 degrees, and the patient is asked to fixate his vision on the examiner's nose. يثبت عينه on the examiner's nose, and then while his head is flexed 30 degrees, the examiner do abrupt or rapid very small amplitude very small movements يعني 10 to 15 degrees to the right and to the left, and the patient is asked to fixate and keep his vision on the examiner's nose. Normally the patient will be able to fixate his vision during the abrupt head movement. الابنورمال ان هنشوف حاجه اسمها catch up saccades. الكاتش اب saccades دي بتحصل لما the patient is not able fails to, these are like corrective saccades, when the patient is not able to fixate his vision during head movement, and this signifies whether unilateral or bilateral vestibular deficits. This is how we perform the head impulse or the head thrust test. We inform the patient, we ask the patient to fixate his vision on the examiner's nose, and then small movements to the right and to the left, 10 to 15 degrees. The second test for the VOR function is what we call the after head shaking nystagmus, or the head shake nystagmus. The patient, the head is flexed 30 degrees forwards, and we do rapid head rotations for 30 times and then abruptly stop the movement, and the patient is wearing the Frenzel goggles, and we check for nystagmus after stopping the head movements. Normally there won't be any nystagmus. Abnormally we will find horizontal nystagmus about 3 or 4 beats to the right or to the left, and this will signify unilateral vestibular lesion. This can happen either in the acute phase, or we can see it also in the uncompensated vestibular, in case of uncompensated vestibular peripheral vestibular lesion. This is right Dixhall Pike, his head in the 45 degrees to the right, and then the patient lies on his back quickly with his neck extended. As you can see هنا لابس Frenzel goggles, and you can see the torsional upbeating nystagmus, which indicates right posterior canalesis. And then afterwards the patient is asked to sit back in the sitting position with his head برضو to the right side 45 degrees, and you can see the reversed nystagmus. Posture and gait examination. Patient's gait should be observed. First, let's start with the gait. We have to observe the patient's gait. Those with unsteady gait should be referred for assessment for peripheral neuropathy. Regarding the posture, the first test for balance and posture by which we assess the vestibulospinal reflex is called Romberg. What's the technique, or how do we perform this Romberg test? The patient is asked to stand with bare foot, and his arms are crossed in front of him. And we test him in two situations. First, with his eyes opened, and then we ask the patient to close his eyes. Normally, the patient can keep his balance and posture while his eyes are closed. Abnormally أو اللي هو what we call positive Romberg اللي بيحصل this patient will experience marked sway upon closing his eyes, and in severe cases he might even take a step or even fall. What does this signify? This signifies either a vestibular deficit or abnormality with the proprioception, with the proprioceptive pathways. As I mentioned, a problem with the vestibulospinal reflex or vestibulospinal reflex dysfunction. The second test is called the Fukuda stepping test. How do we perform it? The patient is asked to close his eyes and take steps in his place, march in his place for 30 to 50 steps with his eyes closed and his arms outstretched in front of him. And please avoid any auditory cues or auditory stimulation during performing this test. The test is considered abnormal if the patient shifts more than 45 degrees, and normally the patient can perform this test normally without marked angular deviation, but the abnormality is shifting to one side more than 45 degrees. Why does this happen, or what does it signify? This happens due to what we call unbalanced static activity of the two end organs. What do we mean by this unbalanced static activity? يعني في one labyrinth is weaker than the other, and usually the patient will shift towards the weaker labyrinth. Now we'll see a video demonstrating the Fukuda stepping test. Now we come to a very important point in our approach to dizzy patient. Hints. Hints stand for ثلاثة tests: head impulse, nystagmus, and test of skew deviation. we already discussed ايه هو head impulse ونعمله ازاي, and how to look for nystagmus. Test of skew deviation ايه هو اساسا, يعني ايه skew deviation؟ هو vertical ocular misalignment. طيب how do we test for this skew deviation؟ بالحاجة اسمها alternate cover test. The test of skew deviation is identified as a central sign للposterior fossa pathology. طيب فين المشكلة بقى؟ putting the three together, head impulse together with nystagmus together with the result of test of skew deviation, بيقدر إنه يساعد primary healthcare physician to distinguish between لو cause of dizziness is stroke ولا acute vestibular syndrome. الستروك ده حاجة life threatening central cause, whereas acute vestibular syndrome is a peripheral cause that is benign. ايه هو يعني ايه acute vestibular syndrome؟ يعني rapid onset of vertigo together with nausea and vomiting and gait unsteadiness, and the patient cannot tolerate the least head motion. Presumably ال symptoms دي collectively كده بتبقى diagnosed as vestibular neuritis, أو لو معاها hearing loss تبقى labyrinthitis. فين المشكلة بقى؟ المشكلة إنه these symptoms اللي هي acute vestibular syndrome اللي هي classified together زي ما قلنا بتبقى diagnosed most probably as vestibular neuritis أو labyrinthitis اللي احنا بنسميهم acute peripheral vestibulopathy. Some patients with the acute vestibular syndrome turns out to be حاجة life threatening condition زي brainstem أو cerebellar stroke that might mimic in its presentation the acute peripheral vestibulopathy. Certain studies have suggested that almost تقريبا 25% from acute vestibular syndrome اللي هم patients presenting acute vestibular syndrome to the emergency department, 25% of them at least بيبقوا turn out to be posterior fossa infarction. So if we have a patient presenting with acute vestibular syndrome, we have to decide, or we need to decide whether this is due to الحاجة اللي احنا in 75% of cases الحاجة اللي احنا متداولة ومعروفة اللي هي vestibular neuritis أو labyrinthitis اللي هي الacute peripheral vestibulopathy، ولا ده a case of واحد من 25% اللي بيطلعوا acute central بقى vestibulopathy اللي هو vestibular اللي هو بيبقى vertebro-basilar infarction أو posterior fossa. تمام. Several studies have stated that the results of these three tests together, the hints together, is almost 70% more accurate even than the MRI and CT during the first 24 to 48 hours the patient presenting by a stroke in differentiating peripheral lesion from a central life-threatening condition. How can we use hints to differentiate between peripheral from central cause? Peripheral اللي هو زي vestibular neuritis from a central cause زي stroke. بنقول إنها when vertigo is not benign hints to infarct. يبقى معناها إيه؟ معناها إن أنا هلاقي الhead impulse test impulse is normal. النستاجمس لما ندور على نعمل gaze nystagmus lateral gaze nystagmus هنلاقي مع الcentral pathology حاجة اسمها direction changing nystagmus. الفاست phase اللي هي احنا عندنا النستاجمس ليه slow phase وليه fast phase. هنلاقي ان الفاست phase بتكون alternating مع الcentral pathology بنلاقيها direction changing, whereas in peripheral nystagmus الفاست phase او النستاجمس بيكون direction most probably بيكون direction fixed. انما في حالة لو لقيت يبقى انا لو لقيت نمرة واحد الهيد impulse normal. ليه؟ لان احنا قلنا ان الهيد impulse ده بيأسس the integrity of the lateral canals. دي حاجة peripheral. تاني حاجة عملت جيز نستاجمس لقيت ان هو fast phase alternating. يعني ايه fast phase alternating؟ يعني الفاست phase بتغير الدايركشن changing its direction. تالت حاجة التست of skew deviation as we mentioned يحصل refixation on cover test. عملنا الcover test لقينا ocular misalignment. all three together الnormal head impulse test مع fast phase alternating nystagmus مع refixation on cover test, this points out to infarct اللي هو central pathology. Vertigo is divided into peripheral vertigo or peripheral causes of vertigo and central causes of vertigo or central vertigo. How can we differentiate between the two? The most important points اللي نقدر نعمل differentiation منها ال onset of the vertigo is usually paroxysmal in cases of peripheral. يعني إيه paroxysmal؟ يعني it comes in sudden attacks, whereas in central it's not. It's rarely paroxysmal. The intensity طبعا peripheral is more severe. Peripheral vertigo is more severe than the central. The duration is less in case of attacks نفسها. Duration of the attack بتكون shorter with peripheral vertigo. يعني duration might be seconds in some disorders like BPPV هناخدها لسه قدام, and may extend to hours. longer durations دايما usually بتكون مع central vertigo. Induced by head position, this is not a must, but frequently it accompanies the peripheral vertigo. Nystagmus is present in cases of peripheral causes of the vertigo, whereas it might be absent with central vertigo. And when we mentioned earlier that we have to record true vertigo, يعني we have to record nystagmus, this means that we have to record during the attack. when there is true vertigo يعني during if the patient is experiencing an attack of vertigo at that time you record the nystagmus but sometimes you examine the patient in different stages of the disease. يكون ابتدى يحصل فيها حاجة اسمها central compensation. At that time you might not be able to record the nystagmus. The nystagmus pattern in peripheral it's unidirectional and it is increased by loss of fixation or actually it can be abolished by fixation, whereas in central nystagmus central vertigo النستاجمس بيكون direction changing يعني ممكن يغير اتجاهه والفixation مش بتأثر في الفixation يعني visual fixation يعني I ask the patient to fixate his vision on a target. This does not cause any change to the central vertigo. كمان في الاوتونوميك nervous system symptoms زي nausea والvomiting طبعا بتكون more evident and more pronounced مع peripheral than the central vertigo. كل ال audiological symptoms أو كل ال symptoms اللي هي related to the ear اللي هي hearing loss tinnitus طبعا بتكون evident with peripheral causes of vertigo and it's rarely present with the central vertigo. On the other hand بقى neurological symptoms, disturbance of consciousness, ataxia الكلام ده كله بيكون evident مع the central causes of vertigo and is absent with peripheral vertigo. This is a suggested algorithm for primary healthcare physicians to approach a dizzy patient. لو patient presenting with dizziness or vertigo أول سؤال هنسأله له whether it comes in attacks episodic ولا continuous. In case it's episodic ايه أهم حاجات نسأل عنها؟ لو في triggering factors ولا هو spontaneous. triggering factor قلنا زي ايه؟ زي head motion زي rolling in bed زي loud sounds زي يعني مش كل حاجة طبعا مكتوبة هنا بس احنا يعني في other causes دي زي كده broad lines ان احنا نفكر ازاي او how can we approach a dizzy patient. يبقى البرود لاينز دي اهم حاجة فيها اول سؤال episodic ولا continuous. in case it's episodic نعرف إذا كان triggered في triggering factor للإبيسود ولا spontaneous. الtriggering factor نعمل Dixhall Pike maneuver نشوف إذا كان to exclude حاجة من الحاجات most commonest cause of peripheral vertigo اللي هو benign paroxysmal positional vertigo. طبعا Dixhall Pike maneuver is not the only test used for benign paroxysmal positional vertigo بس we will know these in details في special senses module. يبقى لو في triggering factors زي motion زي certain head motion زي rolling in bed زي looking upwards يبقى نعمل ال positioning tests اللي منهم ال very well known ال Dixhall Pike maneuver واللي احنا شفنا له فيديو في الليكتشر دي to exclude ال benign paroxysmal positional vertigo. What about لو if these episodes are spontaneous مفيش triggering factor بتحصل لوحدها on its own ساعتها ممكن لو في noted hearing loss يبقى هعمل audiological assessment. I will ask for audiological assessment and this might lead us to diagnose Meniere's disease. Meniere's disease الترياد of hearing loss with oral fullness tinnitus and vertigo. وطبعا بنفرق الفيرتيجو بالduration من ال benign paroxysmal positional vertigo من ال history taking قبل ما go through any examination أو through any tests. من حتى ال history taking هنعرف إن ال benign paroxysmal positional vertigo ال duration of the vertigo is few seconds to maximum 1 minute, whereas Meniere's disease ال duration is longer. It might last 4 hours. Then we move on to another cause of spontaneous. ايه تاني ممكن يكون يعني it comes in episodes and it is spontaneous without any triggering factor. vestibular migraine. مع vestibular migraine طبعا هيبقى في history of migrainous headaches يعني والأورا. And please note that vestibular migraine is classified as one of the central causes of vertigo, not peripheral cause of vertigo. طيب, let's move back to our algorithm هنا لما سألنا whether it's episodic or continuous. In case the answer came that it's continuous, it does not stop. في الحالة دي الأهم حاجة إن احنا نعرف لو spontaneous ملوش أي it was not preceded by medications, it was not preceded by ear trauma. يبقى في الحالة دي أهم حاجة هنعملها اللي احنا اتكلمنا عنها برضو هي الهنس examination. الهنس examination will differentiate between a peripheral etiology اللي هو benign cause زي vestibular neuritis, whereas the other cause اللي هو central etiology حاجة تكون life threatening زي الستروك. زي ما قلنا مع الهنس في حالة السنترال etiology هنلاقي كلمة infarcts اللي هي قلنا هي ايه normal head impulse test مفيش saccades. النستاجمس هيبقى direction changing الفاست phase زي ما قلنا fast phase direction changing. واخر حاجة طبعا abnormal test of skew deviation اللي هي فيها اللي بنعملها بالcover test. البريفرال etiology أو vestibular neuritis مع الهنتس هنلاقي الساكيد present لما نعمل head impulse test according to the affected side. هنلاقي unidirectional horizontal nystagmus direction fixed unidirectional مش بيغير اتجاهه الفاست phase ثابتة. وهنلاقي normal test of skew deviation, and this is very important to differentiate ما بين a life-threatening condition and a benign condition. In conclusion, from a family medicine perspective, evaluating a dizzy patient is not as easy as it sounds. The primary healthcare physician has to rule out life-threatening conditions. He has to differentiate between central and peripheral pathologies. This happens by good history taking and proper examination, and don't forget hence it's life-saving. Accordingly, after that the primary healthcare physician will be able to ask for more investigations or further refer the patient to the proper specialty to further manage the case.